recording and hear more information later. Hey, thanks for turning the recording on. So I think it's reasonable we go ahead and start and get through with whatever we can with the people that are on already. So just as a reminder where we are with all the milestone dates, many of these are past, and that's okay because we're actually mostly caught up. We're going to show you kind of where we are on milestone dates. All the sites are up and running. We're going to hear from all the sites, at the end about any issues that they have, but we are making progress. PCORI is a little happier with us now that we've gotten all of our sites working. Here's what we look like as far as, our red-green milestones. So there's 3 red spots, and those are all related to data. So San Diego, we talked to them about our missed dose data. So we're still waiting on that to come into us at Hopkins. And then the South Carolina data as well. So we will remind people at the end when we get to the site by site to hopefully give us some information on where they are, what the status is, when we might expect to get some of that. As we talk about data, and I think on the next slide, just as a reminder, the original pre-implementation data is 2019 to 2021. We have that, like you heard from most of the sites. We are going to be asking for 2022 data soon. We know that all the registries are hopefully caught up to then. We didn't want to ask for new data until we got some finalized things all set to make sure that when we ask for the data, it's in the perfect exact format that we need it, and we don't have to ask for it again and again. So that's where this iterative part is coming from, and we're going to talk a little bit more about that site by site today. So as a reminder to get everybody in the thinking about mode, the registry data is pretty straightforward because we're used to using that all the time. The VTE prophylaxis administration data is the piece that we're going to talk about. So as a reminder, this is kind of one, every dose of all the total doses, every dose is either given or missed for some reason that is not refusal or refused. So it's really set up this way that, if your hospital is supposed to give 10,000 doses, you can then tell us how many, or we can look at it from the data to figure out how many are which. 80% are this, 10% are that, 10% are that, whatever that looks like. So this is just a reminder of what that's going to look like. And the reason we're putting it here is because in a minute, we're going to show you some questions we have about the data. So next slide. Yeah. So another way to think about it is there are 4 mutually exclusive categories. So, and each site has been giving us data, and then Brandon has pulled out data to look at all the different categories. And we have a few questions of where some of these might fit. So every single dose given seems straightforward, but there's even questions on that. Given is a dose that's actually given to a patient. And then there's this this missed, which, like we just talked about, gets broken into either a refusal, patient or family refusal, or missed for another reason. And there's a whole big laundry list, and we're going to show you what those are. And then we've also decided, there's some other sites or some other times when that dose doesn't really fit into, it's not given, it's not refused, it's not missed, but it really should just be excluded from the denominator. It shouldn't even count as a denominator of doses that should be given. And we'll give some examples of what that looks like. So to get everybody thinking about it, for the next few slides, we have data from each of the 6 sites that has provided the data that we can look at. One of the sites is a Cerner site, so it's a little different. So we didn't put that data in there. It has different things than Epic. These are things that are pulled right out of Epic. So we have 6 sites, 2 we are waiting on data for. So 6 of them, we're going to show you site by site what this kind of looks like. And then there's a few that we have questions about. So if you go to the next slide, so when we looked at this at Hopkins, and we looked at it with, Brandon, who's the data person, Peg, who's our pharmacist, Doreen, who's our nurse, myself, we looked at it And there's some of these things, and we're still not 100% sure what that really means and what category we should be putting these into. So we have a few of these listed. The following 6 slides are a list from each site, and we've put them into what we think are the right categories. And then there are these few that we need your help with to help us try to figure out what that means. And we realize you might not have the answer today, right? I'm looking on the call, Rosemary Kozar. Rosemary, you might not know. You might not be the expert medication person. You might need to go back to your pharmacist or nurse to help us figure this out. And I just use Rosemary because I see your face, I see your name on the screen.
I'm here.
I'm not calling you out.
No, I know. No, I get it.
Exactly. So this is where we're going to go over these things, and we can send the slides out afterwards, and you'll see exactly, we've de-identified the sites so we can talk about it in general, but we can send it back to you with, here's your site and your data. You already know what it looks like because Brandon has already sent this back out. So does that make sense? Like some of those things, if you go back one slide, like I just don't know where to put these things yet. So this is where we can talk about it, but you might realistically need to go back to a pharmacist or an Epic person or a nurse, et cetera. So Brandon, from the data standpoint, did I explain that okay? And or Peggy, Peggy and I went through this last Friday to make sure we thought we had it right.
Absolutely.
Yeah, I agree. And I think our definition of some of these terms may be different than other institutions' definitions too.
Okay. Any questions from the audience before I move ahead? Okay, so we're going to call this the data cleanup by site, for lack of a better term. Okay, so the first site, I think the next, yeah. So here, like I said, these are de-identified. It doesn't really matter where you are. If you recognize this as it's from your site, feel free to chime in. But even if not, we'd love to get some feedback on this. So this is what we've taken. The sites gave us the stuff on the left-hand column. These are the pieces that are pulled directly out of Epic. So imagine, put yourself, you're the nurse at the bedside. You go to give this medication to a person, and then your job requires you to click something of it's been given or it was not given with a reason. And different systems are set up slightly differently, but we get the stuff on the left side, and then a combination of, us at Hopkins, we kind of came up with what we suggest or where it fits in the column on the right side. These seemed relatively straightforward to us. I'll just point out as an example, this one here, fourth from the bottom that says order discontinued. We decided that should be excluded from the analysis because the medication's not been given, but it's also not supposed to be given. So if the order is discontinued, it wasn't missed, it wasn't refused, and it wasn't given. So we decided to exclude that from a denominator. It made philosophic sense to us. And I just wanted people to be on the call to say, yeah, that makes sense to us too.
Elliot, Laszlo here, can I ask you a question?
Sure.
About that? And I think it's a subtlety here, but part of this is education about, when's an appropriate time to hold the order. And I guess there's another piece of data here that we may be missing, is just as a site, or how well we are doing in terms of giving anticoagulation in total. And I guess what I'm saying is that in a way, if there's an order given, we automatically think that it's appropriate where it may not be appropriate. I know we may not have that data, but as a whole, if you look at the data of missed doses or how many doses are given overall, I think there might be some important information there that you might be losing by making that determination. Does that make sense?
Yeah, and it's a great question. We have kind of, I'll tell you what we've done locally at Hopkins. And I'm curious if it makes sense to the rest of the group. We have told the nurses that if the medication's prescribed and it's on their medication administration record that they're supposed to be giving, Elliot Hout is supposed to get 40 milligrams of Lovenox, then that should be given. If they think it should be held for a thing, then that can't just be held because they want to. It needs a prescriber order to hold that medication or to cancel it. And as a reminder, so that's kind of what we've philosophically done. You know, if you remember correctly, we did this Delphi that we're actually now, I would say most of the way through the analysis of, that is kind of where are we with that Delphi survey of getting opinions on when things should or shouldn't be held. That project will give a little more guidance on when to hold or not hold. But we're making progress on that. I think from a data standpoint, it's very hard to know if a nurse holds it, what exactly that means. And that's where I think it's an interesting question of these reasons. Is that okay or is it not okay?
Elliot,
Yeah.
sorry, John at Christiana, I'm sorry I'm late getting on, but just listening to what you're saying, because we're having problems with this ourselves in a couple ways. One, we teach the nurses that they're supposed to give, and that doesn't always happen even with education. The other problem we've kind of come across, and it's two-part, is that they will get verbal orders sometimes from a provider or a or someone else to hold it, and then there's never documentation. So the nurse is then stuck in this, you know, what do I do? Because they've been told to hold it, but it's never properly documented. And the other thing that's going on with that we're finding a lot right here, right now, is that the initial orders, even though there's the system somewhat guides you in what you should be giving, they're finding a huge number of people that aren't receiving proper dosage of anticoagulant for their risk factor. I mean, there's a risk assessment, and either it's being downgraded by the provider or ignored by the provider, and what is ordered is not what the recommendation would be for that patient. And I don't know if you guys are having
No,
that.
John, so you bring up two really good points, and I'll address the first one first and the second one second. So the first one is, what do you do with oh, you know, I'm the nurse, I don't think you should give it because the person's going for some ortho procedure. And then the doc's like, yeah, fine, don't give it. And then it never makes it to the chart. We have been pretty militant about if it's not if there's no order to discontinue the med and then restart it later in the day, or there's no order to hold it, that is a missed dose that should be given. So we can talk about that as a group of how to deal with that. But that is a really, that's kind of what we've decided to do. We can talk about that as a group first and then come back to the second part. Although I'll tell you the second part is a whole different issue. What is best practice prophylaxis? Who should be getting it? What is the dose that should be ordered? Should that be dose adjusted by weight? Should it be dose adjusted by TEG? There are many, many different questions. We have been very, not lenient. We've decided that that is not the aim of this project. The aim of this project is if Laszlo writes an order for Lovenox, it should be given. We have not told Laszlo, you must order Lovenox in this specific way, right?
Yeah.
We do not have, we know it's not the same. We know Lisa Knowlton and Annie Warner are using potentially different risk assessment tools and different standardized risk, standardized dosing. Some might be modifying it based on, like I said, weight-based or TEG or other reasons, anti-10A, et cetera. This project has nothing to do with making sure people get the right prescription.
But Elliot, maybe I misinterpreted the question. It sounds like maybe your protocol or guidelines are maybe a little bit too complicated. So it just, everybody's supposed to get it. There's not really a risk assessment. And then it's just easy. And then you can decide the whole dosing is a whole different thing. But maybe I'm misinterpreting what you said, but maybe it's just too complicated for the risk assessment.
Well, I think different people, we do not have a standardized risk assessment tool that we have asked all the sites to use. We have a copy of all of yours. And I've seen, and it turns out, Rosemary, yours is actually more complex than others. It's multiple pages. I mean, we looked at it. It's interesting because it has a whole piece on how are you going to adjust and who gets it and all these other
Oh, yeah,
pieces.
it's a whole time. But
Other places have different, when you talk to Bill Gertz about it, he said, yeah, everybody gets low molecular weight heparin. But then, there are issues with, well, this patient has an epidural catheter for rib fracture pain. So therefore they can't get twice a day enoxaparin and we have to give them this. There are these other nuances that the issue of patients with TBI, it's an ongoing debate. And, I personally give those patients low molecular weight heparin. There's very good data on it, but others don't. So this really is not the project to standardize the risk assessment or the prescription. This is the once the doctor orders it, it should be given. I don't want to oversimplify it, but does that answer your question, John?
Mine wasn't a question. I just was kind of compounding on the statement that you made. And I think sometimes is what you're going to see is in the data that you get, it's going to make the data dirtier than it would be otherwise, just because in the background you have things going on that we can't control for. And at the sites we're pulling our hair out sometimes trying to get some consistency, and you get so many different answers from different people. I mean, routinely anesthesia guidelines, if you're going for a block, anesthesia guidelines say you can't have anticoagulation within a certain amount of time. But at the same time, those anesthesia docs won't necessarily come by to write a hold order, because how often does your OR time change based on the whim of whatever else is coming through? So, and then the nurses are sitting there going, they understand the procedure, they're giving it, they're not giving it, they're not sure what they do. And we also say the same thing, unless you specifically have an order, you should be giving it. But we do have that occasion where like they get this verbal order from somebody that comes by and says, hold this dose. They don't put it in the system. It's, the nurses treat it as a verbal order to hold because it came from a provider, but there's no documentation from it. And, it just dirties the data that I see coming through out of these when you look at, trying to figure out what really went on. It's hard sometimes to just say, mainly this is a nursing education piece, but you have people, I think there kind of needs to be and I don't know how you do this, a provider education piece that goes along with this, that, your nursing can't be your final block of a mistake.
Totally agree, John. And I think we've been pretty, like I said, we've been pretty clear. The nurses, at least at Hopkins, are told, we don't do verbal orders unless it's an emergency. So you can't say, oh, I got a verbal order for Tylenol. I can't, they can't do it. They won't do it. They say, great, well, then log into the computer and put in the order.
Yeah. The problem is that a physician here can bypass that by saying, okay, take it as a telephone order and walk away.
Yeah, we don't do that. So it's hard, and it's hard because different places do it differently.
Yeah, Elliot, I'm not, this seems like the most reasonable approach. I just think that, there is some potential for data to be missed. It would be interesting as a, down the road, that could be a potential area of study, is just to look at the variability between institutions about how much prophylaxis is given.
Totally. And the nice thing about it is, for those of you who've been involved in, whether it's CLOTT1 or whatever, all these data, once we have all the data and the main projects are done, if you want to help with, oh, here, I have a really good question, because now we have dose administration by patient by dose for 9 trauma centers across the country for a year's worth of we can do 1 million secondary analyses.
Yeah.
So, and variation between site is real. All these things are real issues. So with answering those questions, this is kind of this site's list. Is there anything on this list that people don't like or don't want to?
It seems odd that it's being held when patient is MPO, unless it's an oral agent.
Totally get it. So Annie, we have seen that. And I think there's a few different possibilities. First of all, this is likely, there literally might be one or two of these. So Brandon can certainly tell us and pull us the number. So there's a few possibilities. Possibility number one, these are thousands and thousands and thousands of doses. I personally think there's some of those that are a clicko, right? Like, oh, I meant to click this thing and I clicked the thing right below it. And then it's like, fine, good enough, I'm done with it. So I personally think some are like that. I think the other possibility is, oh, Elliot Howe is going for surgery. He's going to get his femur fixed and he's NPO. And that means he should also not, he's NPO because he's going to the OR and therefore he should get this medication held. Like it's in someone's mind linked. But I totally agree. We all agree heparin is not an oral medication.
I'm just worried if we narrow it down to just two things, either refused or missed, then we lose a lot of the detail of the data where things
Yeah,
are.
so I guess the question
wrong
is,
and things.
right. So, I mean, we still have the data on patients NPO, but what do you want to do with that? Say there's, your doses for a year, there's 10,000 doses and there's 2 doses that say patient is NPO.
So
I don't care about, but if many are just omitted, I mean, these are all reasons why patients didn't receive the proper dose.
Right. So that's why we called that, for that specifically, we called it missed and it wasn't for other than refused.
I don't want to call out this particular site, but just as an example, there were 592 missed doses over the course of an entire year. More than half of those were refused at this particular site. And a lot of these reasons that aren't something like patient condition or NPO, for example, was clicked 4 times over the course of an entire year. So I don't think that we're going to get a lot of information from going into the individual reasons that were selected just based on the number of times that doses were missed.
Yeah, and I think we're not going to be writing about this idea that it's NPO, but I think at some point, just think of what this pie looks like. Like, here's the pie chart. It's either given, it's refused, or if it's missed for something besides refusal. And that is like, those are 3 mutually exclusive categories and everything has to be one of them. Or it's excluded from the analysis, excuse me. And Annie, if we find out that, hey, there's people using this a lot, we can certainly bring it back to the John or the program manager or whoever and be like, hey, can you stop clicking patients NPO? Like, that doesn't make sense.
I do think you're right. I think it's probably they just were going down, they clicked it, and didn't feel like going back and fixing it.
Yeah. So, okay. But it sounds like there's no, people are in general okay with the way we've classified these. We have a few more that I want to go through. If we can go to the next slide. So there's 5 more of these. So these issues are this MAR hold and MAR unhold. And honestly, this is something I think each of the sites probably needs to go back to their pharmacy and or nursing colleagues to help figure out what exactly does that mean at your site. Because I think it might not be exactly the same as it is at our Hopkins. Our Hopkins Epic site is different than et cetera, et cetera, et cetera. So I think the rest of them, we can look at this list and make sure. I think, obviously some of them are very straightforward, but that the MAR hold, MAR unhold, I don't know if that's something Peg or Doreen, if you want to talk about or give an opinion or kind of explain what you think it means, at least for us.
Peggy?
I was about to say, Doreen.
So the way I thought of it, and you can correct me if I'm wrong, Doreen, is that sometimes when a patient's getting set to transfer from like an ICU to a floor, they will sometimes do the orders ahead of time, but then put them on hold until they're actually transferred. Yes, and then they have to be reviewed by the pharmacist before they can actually be activated. So sometimes you've got this dead air, for lack of a better term, in regards to a patient being transferred and then you having access to your medications to be able to administer them.
Yes. And then the unhold is they're at the new floor. They're all set up. We can unhold them. So we have orders.
So it becomes this question of, I still don't know what to do with them.
Yeah, I think, Elliot, you might need to figure out what they mean, because it's for us, the MAR hold would mean they're in the OR. So it might be like an individual site to kind of give some feedback to them, maybe reassess.
Exactly. So I think that's where we will send these slides back to you, and we'll send you kind of your slide that's re-identified with, hey, you know, Rosemary, here's your slide, you know, et cetera, Laszlo, here's your slide. So you can bring it back to your group and help us figure out you know, here's what it means at shock trauma, here's what it means, et cetera. Does that work?
Yeah.
Okay. Sounds good. So this is number 3, same thing at the MAR hold. You know, we put this thing here, needs medication reconciliation. Same thing, it's gonna need to go back to your site. What exactly does that mean? Different sites, that's waiting for a pharmacist to do the med rec, or is it waiting for a nurse to do the med rec? Can the nurse override that, or is the nurse not supposed to override that? This is another one of the things that needs to go back to your nursing and or pharmacy colleagues to help us figure that out. We thought maybe exclude, but I think this is where we need to have each site kind of tell us what it fits into. Here's another one. It has MAR hold and MAR unhold. And then this site, we're still waiting on the secondary reasons if it's missed. So for this one, and I think we would have to change where it says missed other than refused. We don't yet have the breakdown. The way this system is set up is first you click missed, and then if you clicked missed, then it asks you for a secondary question of, you know, patient off the floor, refusal, et cetera, et cetera. So I think we need a little bit more data from this site. Brandon, is that my understanding? Did I get that right?
That's correct. At each site, the slide before this had one point of documentation for given, missed, refused. This site has the secondary for the reason for non-administration, very much like the first slide.
And obviously I'm very optimistic that reason is required, right? If I click missed, it requires me to say a reason for it. If not, I don't know what to do with those. We'll just lump them all into missed, but we won't have the breakdown of refusal versus other. So, okay. Another site, and you can see just as you look at all the different slides, it's just so different. Like each site really is very, very different. So, you know, even this one, you know, the other site had NPO, this says nothing by mouth, same idea. This list is super long, the other lists are shorter, but the same idea. We have the MAR hold and the MAR unhold here. I think this might be the last one. Oh no, there's one more, sorry. So same thing over here. It's kind of the same question of what do we do with the override pull and the unreviewed transfer orders. We just need a little bit of guidance back from your nursing pharmacy colleagues of where do we bucket those. But we do see reasons like when it says patient sleeping, you know, hopefully the education is you should wake them up. Just like you wouldn't let them sleep through their vancomycin or their beta blocker or their whatever. This is just important. So we're kind of reminding people as far as an educational standpoint, that's an important piece. Like normal glycemic and NPO, like these things are also, like it's probably a standard drop-down menu. It's not a VTE specific drop-down menu. And hopefully those are relatively small numbers. So before we go on, any questions about that, please? I know it was kind of painful to go through, but I think it's an important discussion point. And if each person can, you know, just work 15 minutes or half an hour to get us some information back so we know where to bucket them. And then once we have that, we now have 6 sites, we can start to get some preliminary data.
Elliot, it's Rosemary. Could we just get the number of each of those? Because, if it's one versus 1,000, we might dig deeper and,
Fair, that's a fair question. So if you, for example, Lizette, could you go back a slide? So you're asking that when we send this back to you, Brandon sends another column that has, 4, 7, 11, 1,000, just so we
yeah,
know how
if
many.
it's easy. If it's not, that's fine. It just might be helpful
Totally,
to.
It's a fair thing
Okay.
just to get a feel for how much work you're gonna do
Yeah.
for it. I think that's a reasonable ask. I mean, hopefully the vast majority, we know the vast majority are gonna be given. But so I don't want you to look at the percent of the total. It's the percent of the not given pieces. So for something that might be, oh, it's only 4 doses out of 1,000 that are ordered, but if it's 4 doses out of 100 that are supposed to be given, that really is now 4%. Now it's real, especially if you add up 4 of these, 2 of those, 3 of those, and 7 of those. All of a sudden, it gets bigger faster than you realize. But we can certainly, I don't think that's a difficult technologic ask. Brandon, any concerns about doing that?
No, the numbers are already included in the spreadsheet.
Okay. Perfect. So we can do that. Any other questions before we move ahead? Okay. Great. So nurse education, most of the sites have really stopped getting a lot of people. It would be great, as you get new nurses, just keep reminding people they should be doing this new online education. We're still hoping, Rosemary, for a few last completers. The manuscript for the nurse education survey, we've kind of stopped the numbers for that, but we will be putting these final numbers into the big final manuscript. Our internal goal was, as you remember, everybody was 80%. So it would be nice if we could try to hit that 80%. So if there's any way you or Paul could help us, that'd be awesome.
Yeah, well.
I understand.
I'm frustrated. I'm sorry.
No. I get it. It's frustrating. And in some ways, this is typical real world implementation, right? This is not a randomized trial where you can do everything perfectly. This is real world. And it's great to see that some places hit 100%. But in the real world, we understand that, one of the sites couldn't get 80%. That doesn't surprise me. And just so you know, this will be de-identified in anything we end up publishing. So, okay. Qualitative interviews. So as a reminder, we picked, this is the information from Danny. I think I saw Danny on the call. Danny's been doing a bunch of these interviews with people, and we're making a lot of progress there. There's a few that are still outstanding. We're over halfway there from my quick math. It looks like 15 are done and 10 are left to go. Danny, did I get that right?
We have about 11 completed, 14 to go.
Okay. So we're in the ballpark. We're about halfway there. So just as a reminder, I think I counted all roles. I didn't realize that was separate. So I think if we can just keep pushing your sites to get these people to agree and find a time to meet with Danny, I think this is going to be very helpful for us as we start to figure out facilitators and barriers for the different parts, for the nurses, for the IT builders, for the nurse managers, et cetera, et cetera. So Lizette is still helping us try to schedule some of these, but if you could just remind your team how important this might be. Lizette, anything else from you on that?
Yeah, I'll send some follow-up emails directly to the contact that was shared with me, and then copy just the PI and program person on there, just so we can get these scheduled with Danny.
That'd be great. Thanks.
Thank you.
So next up is milestones by site. Anything people want to talk about before, we still have 20 minutes left. Any other big ticket items or things that are general before we go into the specifics of the milestones by site? Okay. Sounds good. So Christiana, John, I heard a little bit. I think we're launched. Literally, you guys were the first one. You're almost at a year. Any issues, John, Annie?
No, I don't think so.
Okay. Sounds great. We've got your data. We're underway. Next up, Maryland. We talked a little bit about the nurse education, and I know it's hard. Any other issues with you, Rosemary, or anything else we could do to help? Or
Not that I'm aware of.
okay, in general, thinks it's been going okay.
Mhm.
Great. Laszlo.
Yeah, I think I get the list of alerts every Friday, and so things seem to be going along. I guess I'm also interested just in finding what data we're missing, because I think there was some concern of us not having the reason. And so when I think we had that discussion a couple meetings ago, and I did meet with our nurses and like pulled a couple of these charts, and we do have the reason documented in Epic. And so if we don't have that data over to you, it might be kind of a data pull problem. But I was reassured to see
Perfect.
that we are recording that.
Yeah, and like I said, Brandon will be sending between Brandon and Lizette, each site's going to get an email with here's what your data looks like. And I honestly don't remember if you're the site that has the secondary question or not. But you'll find out when we get that email.
One
Brandon,
thing
that off the
I
top of
was
your head.
pleased to see is that a couple of these, and it's all nurse dependent, but some of the nurses actually documented patient refused education given, which I think was nice.
That's great. And that we call that the halo effect. So of this idea that, the first time the alert fires, and it goes, and then a nurse manager talks to them or whoever's doing this intervention, and they reminded about the materials and they're shown where they are on the webs, all these other things. After that happens, once or twice or even 3 times, people are like, oh yeah, I know what to do now. If a patient refuses, I'm going to preemptively show them the video, give them the handout, etc. So we found that there's less interventions over time, less official interventions over time, because people kind of know what to do. Does that make sense? So you're explaining what we've seen before, which is nice.
Yeah, that's great. Thank you.
Okay, Stanford. Lisa, anything cooking?
No real updates. Everything's going smoothly on our end. Shelley just wanted to know it's marking about a year for us in terms of providing data. So she just wanted to know when you wanted the next set of data from us.
Absolutely. And it's a great question. So I think what we're going to do, what we've decided is once we get the data fixed on the things that we just showed you, then we're going to ask everybody for, hey, can you give us all of your data for all of 2022? And then that'll at least give us some post data. You guys launched September 7th. So we'll have at least, some post data, September, October, November, December. And then soon enough, we'll be able to hopefully, ask for at least the first half of 2023. Once we know we're pulling the right data.
Okay, thank you.
Okay, perfect. Lancaster, I don't know that I saw anybody on from Lancaster. Okay. We'll move ahead. Wisconsin. Summer vacation. Okay. Utah. I think it's the same issue.
This is Kelly from the University of Utah. I think the only update I have is that we were finally able to get the real-time alert live and where we were actually able to track it. So that's kind of where we're at.
Okay, so does this launch date, is that not the right one? Do we have it incorrect?
Let me look at, so it's difficult to say because one department, our acute care department, was able to launch on that date, but the ICU took a little bit longer. And it was just due to the way that it was built with the MAR actions. So I can get, I don't know if it's helpful to get an official launch date from an ICU, just from that specific department.
I think it would be helpful to give us as much information as possible. Because I think, especially in a pre-post analysis project, we are kind of counting on, everything until April 20th is pre, and then April 20th moving forward is post. I think if we're going to need to figure out a way that there's kind of 2 launch dates at your site, we're going to have to figure out what that looks like.
Okay,
But we'll take some notes, and Lizette, if you could work with them on trying to figure out the date issues, and then we're going to have to work with Brandon on, okay, well, here's the date issue. What do we do when it's separated out? But good to know. Okay. San Diego.
Yeah, our missed, we ended up having to go through our CTRI to get the missed dose data, so it's in the queue with them, and hope to have it soon. Checked in this past week and it's not done yet.
So I'm knowing what my place is like. Is that like, oh, we'll have it in a week, we'll have it in a month, we'll have it in a year? Any ballpark idea, Todd? I realize it's hard to, I'm not going to hold you to it, I promise.
My
Just give it a
guess
ballpark
is,
idea.
my guess is more than a week and less than a month.
Okay, fair enough. If you were to ask me on something like that, I would have said more than a month, but less than 6 months. So I'm glad to hear it's less than I was.
Yeah,
concerned.
I think we're a little farther down the line for it to be any more than a month, hopefully, but fingers.
Okay. Sounds great. And then now that I think when we talked, Brian Clay had been on the call, and I think he was going to do a little bit of work up front to mitigate the issue we had that we just talked about the reasons for missed doses and things like that. So do you guys have a list, or we'll have to wait and see what it looks like and then make the decisions?
We'll need to see what it looks like. He did communicate with the data folks at our CTRI up front, but we'll have
Okay.
to look at it.
Okay. Sounds good. So yeah, obviously as soon as you have that, let's get a look at it. And then one more. So South Carolina, I don't see that I saw Bruce on. Anybody else from South Carolina? Unfortunately, no. So they're a little behind. We're still working on data from them. So Lizette, I know we've been in touch with them. So, maybe another reminder for data for you, me, Brandon, Michelle, et cetera.
Yeah, I'll do some follow up with them.
That'd be great. Thanks. I think that's it site by site. Any other, like I said, I'll just update you guys on a little bit of the other things we're doing. So there's a draft of this nurse survey paper that we're working on internally. And then there is the Delphi project that we're also internally working on as well. And we'll have, as soon as we have stuff to share, we'll get it out to the group. Anything else from the center people? Lizette, Michelle, is there anything else we missed?
Nope, not for me.
Sounds good. Anything else from any of the Hopkins people?
Not for me.
Okay, sounds good. Anything else from any of the other sites? Okay, I think this was productive. We will be in touch with specific asks about the data to finalize these last little pieces that you'll need to work with nursing and pharmacy and get us some answers. But thanks a lot for pushing ahead, everybody.
Thank you, everyone. Have a good week.
Bye-bye.
Hey, talk to you later.